reduce the volume, otherwise it's too loud. Okay, hope this is good. Okay. First one is influenza drugs, drug name oseltamivir. Then drugs for COVID-19, nirmatrelvir, ritonavir, combination drugs. Then pneumonia drugs, that's a major topic we are going to discuss. And then there will be upper respiratory diseases at the end. I classified into pharyngitis, otitis media, sinusitis. Those will be at the end of this lecture, last slides. And major topic will be pneumonia. We have CAP, community acquired pneumonia, HAP, hospital acquired pneumonia, and VAP, ventilation associated pneumonia. You already learned all the pathogens and all these in different lectures. Therefore, it's going to be easy for me. I will be directly jumping into drugs. Also, you will have clinical lectures here also. But keep in mind, this is just a basic introduction for your pharmacology. So whatever I am teaching this is going to be like the basics. So later, after maybe a year, when you start clinical practice, you are going to understand that difference, how these drugs are different and what to choose. But I'm going to give you about 12 to 15 cases. So you are going to, I will be able to give you the information to treat about 15 different types of patients. But keep in mind, before you finish this 2 hour, I want you to at least be able to teach 10 patients without my help. Does that make sense? Okay, so I'm going to go like straightforward, direct. But this always, like other diseases, it is patient to patient. But there is American Thoracic Society and infectious diseases updates. That's what you always have to refer. So I have the links here. See, when you treat these kind of diseases, you always have to trust on that recommendations from these infectious diseases and all these societies. The reason is there is always resistance in the society, and so there will be always updates. So you have to depend on that in the early stages of your career. Do not just memorize and treat the patient. That won't work. Okay. So I'm all this today's lecture. I took all the content from the CDC, linked to this infectious diseases and American Thoracic Society. So please make sure to read that also. I'll give you those links later. So let's start. So here are the drugs for pneumonia and also for pharyngitis, otitis media. Amoxicillin, that's what we're going to discuss first. You already learned all the basics about this pharmacology before. I taught you last year. But today, we are going to go this one last time, all these antibiotics again. So we're going to discuss the indication, mechanism of action, pharmacokinetics, major one, drug interaction, if any, and the contraindications, if any. So whatever I'm discussing today, you have to learn that without any excuse, because it's very important, okay? First, the 65 slides, make sure you study. I think I added 77 or something like that, but 65 slides for your exams, okay? So let's look at it. Amoxicillin. So if a patient has pneumonia, usually community acquired, very healthy, no comorbidities, nothing to worry, like a very healthy patient, outpatient, you have amoxicillin choice. We're going to discuss in future, but there is history of antibiotic use in last 3 months, or there is a lot of, if you are suspecting a beta-lactamase producing bacteria in this, you are going to go for amoxicillin clavulanate. We will learn those are penicillins. Then azithromycin macrolide. Old days, maybe until recently, everybody go for azithromycin. No more. We are not going to do monotherapy with azithromycin because in nationwide, more than 25% of resistance for that drug. So do not even think about giving macrolide as monotherapy because of the resistance. So we're going to discuss those topics. Then doxycycline, good drug. We will do that because not that primary, but sometimes we will combine, or if you patient cannot tolerate, or we will discuss all those details. Then levofloxacin. Until recently, in all these lectures, I used to say that is not a go-for drug for anything. But here, if a patient is pretty sick, if you need a lot of coverage, this is one of the respiratory fluoroquinolones. That is, out of all these levofloxacin, fluoroquinolones, levofloxacin is a best drug and well-tolerated drug, and it can cover. Of course, it is dangerous with a lot of adverse effects. We will discuss again, but this is a good drug for combination or even sometimes CAP monotherapy. We will discuss those. Ceftriaxone and azithromycin. Okay, ceftriaxone, this is a big drug. This is a third-generation cephalosporin. Hospital setting. We're going to use this for pneumonia a lot. You are going to do that. Then sometimes we combine beta-lactam with the doxycycline, even in the outpatient community acute pneumonia. Reason, if you need a broader coverage, because like azithromycin, doxycycline also will cover the atypical microbes. Then why I didn't say that azithromycin, we mentioned that, we will discuss again, not a monotherapy, but still, when do you use azithromycin? There is chance. If it is like a very proven, or you assure that the patient has mycobacteria or atypical, then you can go for azithromycin. No, otherwise, not a monotherapy. Then MRSA, straightforward, 2 drugs. You can easily study like that, and then you can have other choices. But now, recommendation is vancomycin first choice. If sometimes vancomycin intolerable, or if the patient you cannot get, if you don't have vancomycin available, it's not possible, but it is. But sometimes there is vancomycin resistant. In those cases, you have linezolid. Oh, okay. So this is linezolid. Linezolid has another thing. It's an oral drug. Okay, we're going to discuss again. Vancomycin, there is oral drug. You should never treat pneumonia with vancomycin oral. Those are tricky questions board exam can ask you to test you. So make sure vancomycin oral is not for pneumonia. Vancomycin IV is for pneumonia. But linezolid, if your patient, you need to take the patient to send them home, and you still have to cover that MRSA, you can keep them on linezolid, or even in the hospital setting. Reason, we have oral drug is available linezolid. We will discuss all those details. Then Klebsiella pneumonia. This is another one with a straight indication. Usually I don't give you first line, but this we can straight say that there is first line antibiotics there for Klebsiella pneumonia now. The indication is directly imipenem cilastatin. Then Pseudomonas coverage, of course, hospital acquired pneumonia. Okay, rarely CAP you can get it, but not often. But for the ventilation associated, you have Pseudomonas coverage you have to do. What do? You need to look at the drugs which can kill Pseudomonas. Cefepime, then ceftazidime. These are 4th and 3rd generation cephalosporin. Then you have the penicillin, piperacillin, tazobactam, imipenem cilastatin. So these are the drugs we are going to study in detail. These are the big ones. So let's start. Okay, ready? Okay. Drugs to treat influenza. There is recent, sorry about that. Okay. Flu is highly contagious respiratory illness. It's caused by influenza virus. 4 FDA-approved antivirals to treat influenza is oseltamivir. It's a pill, oral pill available. Peramivir, IV now. Then zanamivir, inhaled, that means you can give that to kids, zanamivir. Balaxavir, pill available. So the first three you can learn for our class test also. Approved for early treatment, used within a day or two of getting sick. So there are contraindication, fourth one. Balaxavir, not for pregnancy, breastfeeding, or hospitalized patient. Then the second, peramivir, and the third one, zanamivir, are not for asthma or chronic lung diseases. But most commonly prescribed and used drug is oseltamivir. So that's the prototype drug we are going to learn today. Then, okay, viral target proteins. Okay, flu virus has different types of proteins in their cell, surface proteins like neuraminidase, hemagglutinins, then matrix proteins, etc. So the drug oseltamivir targeting on a surface protein called neuraminidase. And another drug, amantadine. So this is not the go-to drug for, still people use it, but I'm not going to teach you this as a primary drug reason. This is actually now a Parkinson's drug. We will discuss why. So the drug we are going to learn is oseltamivir. Indication. Why is it a good drug? It's a well-tolerated one, effective also. This can be used for both prophylaxis and treatment. One more time. Prophylaxis, if a patient has, one patient from nursing home reported the flu, then you need to give all the other patients, then pick this drug, very good. Then same thing about institutions, other treatment. If you're getting a patient with a flu symptoms, you can give that. Adults, even it is tolerated in pregnant females, okay, that's a good one. CDC, although not a part of FDA approved indications, use of oral oseltamivir for treatment of flu in infants younger than 14 days old is recommended. This is from CDC website, so you always have to refer up to date and CDC for final assessment. If you have doubt, call them and ask when you treat, but you will learn that later. But for the time being, as for pharmacology, this is what you're supposed to learn. Okay, then like I mentioned, zanamivir is approved for treatment of flu in children 7 years and older. So how oseltamivir work? It is a neuraminidase inhibitor. That means flu virus has a lot of surface protein. One of the surface protein can block to by oseltamivir. Therefore, you can completely restrict the growth of flu virus. Very good. Prevents newly formed virions from leaving infected cells. Restricts influenza virus in cell to allow immune cell to work. Okay, very good. Then it's a prodrug. Oseltamivir, orally very well absorbed. Then it is converted into oseltamivir carboxylate, which is the enzyme. It is hepatic esterase enzyme. So you may be asking, why don't we give oseltamivir carboxylates? Because that is also available as a drug. Because that has very low oral availability, very less than 5%. Therefore, scientists are smart. They are using the drug oseltamivir. It gets into the patient's liver and it is metabolized into active component. Does that make sense? So oseltamivir carboxylate is an active drug which can kill the virus. Okay? So you can read all those details. Okay? The patients get, okay, the question distribution, there will be at least one question out of 8 questions will be adverse effect and one mechanism of actions like that. We will discuss that in the end if there is a breakdown, but keep in mind, if I give you specific adverse effect, just study that also, okay? If not, you don't have to worry about that, okay? Insomnia is one of the adverse effects of oseltamivir. This is a drug for flu therapy. There is a contraindication for this drug if you combine with a clopidogrel, inhibit hepatic esterase. Therefore, because remember, oseltamivir is a prodrug. If you are using a prodrug and the enzyme which is activating that drug is inhibited by another drug, you should never combine. Does that make sense? It's a very straightforward contraindication. That's the only thing you have to learn from that one. Probenecid, if you add, it will reduce the renal elimination. That's one point. But okay. Other drugs, amantadine and rimantadine, these are, see, good for influenza A, but not for influenza B viruses. It's antiviral drug with a mild anti-Parkinsonian activity, but CDC does not recommend, these are updates, does not recommend treatment or prophylaxis of influenza A with amantadine due to high levels of resistance. Keep in mind, because when you go to practice, this is what, refer to the CDC and then take decisions, okay? I don't want you to trust textbook of people for treating patients. All the patients will be individualized treatment. Use your brain, be smart, and refer all those links. I will give you some of them today. Okay, amantadine is now used mostly for Parkinsonian disease, but still, because it is considered it is effective for influenza A, I'm going to give you the mechanism of action. This is an ion channel blocker. So the virus has ion channel, M2 protein, viral M2 protein will be blocked. Are we good? Okay. The drugs to treat COVID-19. Same thing, because it is pandemic, you can get these questions for the board exam also. So therefore, also upper respiratory and lower respiratory symptoms. So learn at least 1 or 2 drugs for this also, COVID-19. So 2023 FDA approved combination drug, very important to learn. It's called Paxlovid. It is a brand name, but study the pharmacological name, nirmatrelvir, co-packaged with ritonavir. You need to learn why are you co-packaging with some other drug. There should be a reason, right? So for the treatment of mild to moderate coronavirus in adults, okay, nirmatrelvir is a SARS-CoV virus 2 main protease inhibitor. Okay, we are learning different mechanisms. This one is COVID-19, unlike flu virus, COVID-19, one is protease inhibitor. But we are adding another drug, ritonavir. Ritonavir is a HIV-1 protease inhibitor. That is actually an HIV patient's drug. Why are we giving to COVID-19? Reason, it is not to treat the COVID-19. That is, it is not going to kill the COVID-19 virus, but this drug is a CYP3A4 inhibitor. So now what you have to learn is what is behind this. So the next 2 slides discuss that. Okay, let's read this also. Ritonavir, which has no activity against SARS coronavirus on its own, is included to inhibit the CYP3A4 mediated metabolism of nirmatrelvir and consequently increases in this drug's plasma concentration to levels anticipated to inhibit SARS virus replication. Okay, combination drug, nirmatrelvir and ritonavir. It's called Paxlovid for SARS coronavirus. That is the indication. It can work on all coronaviruses. That's why it's a very effective and commonly, this is 2023, so you're going to see this a lot in your maybe board exam, clinical practice. And mechanism of action. This is SARS-CoV-2 main protease inhibitor. Why is it important? Very effective. It covalently inhibits. Anything you see covalently, you can trust that, right? Covalent inhibitor directly bind to the catalytic cysteine residue of cysteine protease inhibitor. Incapable of protein, so the virus cannot process all the polyprotein precursors so that the new virus will not be actively formed. Block the viral replication. Very good. Pharmacokinetics. This drug, that is nirmatrelvir, going to be metabolized by liver. CYP3A4, important point. Another important mechanism of action is important. Second important point from the slide, it is metabolized hepatically with a CYP3A4 to reduce metabolism, because as soon as the drug absorbed into the body, it is going to go to the liver. The moment it gets there, it's like CYP3A4 is going to chop down very fast to stop the metabolism, because patient has a lot of virus, coronavirus in their body. The drug has to go and kill all the coronavirus, right? Therefore, you need to keep the drug more time in the body. That is why we're going to use ritonavir. That is an inhibitor that completely blocks that CYP3A4. Therefore, this is going to be effective. One adverse effect to learn out of a long list, but it's a pretty well tolerated drug. That is metallic taste, okay? Ritonavir, when you combine, that drug is combined. It's like amoxicillin clavulanate. It comes with a combination. So it is also a CYP3A4 inhibitor. Ritonavir is a most potent CYP3A4 inhibitor in clinical use. It is often applied as booster for drugs with a low oral availability due to CYP3A4 mediated biotransformation. Okay, so it can inhibit CYP3A4. Ritonavir, CYP3A4 inhibitor. Therefore, you combine with the nirmatrelvir. Does that make sense? Okay, so this is the picture. How does it work? So the ritonavir drug will go and bind, irreversibly binding with the CYP3A4. It will wait until the CYP3A4 is inactivated. Irreversibly blocks heme-containing protein. How is it recognizing? If you wanted to know the detail, ritonavir can bind with this heme-containing CYP3A4. CYP3A4 has heme. That's what it says, and it binds with that and strong ligation, and until they are unmodified, so it's going to be inactivated. That's all. It's easy to understand, and then this molecule can undergo destruction. Therefore, CYP cannot chop the coronavirus drug. Does that make sense? Fair enough? Okay. The next drug is molnupiravir. High-risk patients. Earlier we said moderate and early onset, but this one high-risk patient COVID-19 within 5 days. Alternate antiviral therapy. Nucleoside analog, inhibiting nucleoside. It's actually mainly cytosine, but it can mimic as uracil also. It take over the RNA of the virus and it trick the virus. So that virus will be producing a lot of bad RNA, so that they're going to die because of the mutation. Very easy. And people report that it's new, but we don't have to study adverse effects. Okay. Then remdesivir. That is actually a nucleotide analog. See, molnupiravir. If you like to compare, see, the first one was nucleoside analog. The second one here is nucleotide analog. The previous drug combination we studied was protease inhibitor. Does that make sense? Okay, good. The next one, the real hero of today's lecture, bacterial pneumonia. Okay, there are viral pneumonia, there are fungal pneumonia. Fungal, I already taught you in the first year. Remember amphotericin B, aspergillosis pneumonia, then Pusaconazole, Voriconazole, Isavuconazole. Remember all those stories? There are 3 or 4 drugs available for pretty serious pneumonia. So that is fungal. Okay, so you can revise those lectures. Okay, because we don't have time. That's why I would like you to learn this better. Okay, and refer those lectures. And okay, like I said, we are going to, you can study this lecture first. Okay, even if you are attending the class today, you go ahead and, I know you have multiple lectures, but still, I know you have another pneumonia clinical lectures. At the end of the day, if you are too tired tonight, at least tomorrow, I want you to study this pneumonia lecture once and go back and listen to this lecture one more time. Please do that. I usually never say that, okay? Because this is a pretty important lecture for you. You're going to treat a lot of patients with pneumonia, and it is not complicated. It is very simple. Trust me, I will make it very simple. But it is very complicated if you think about it. When you, at this point, you need to learn some tricks and basics so that you get a foundation. That's what we're going to do. Okay, always trust. Do not look, okay, you can refer textbook, all the site, everything. But trust directly the direct sources. So I went to CDC and took the, like I said, infectious diseases and American Thoracic Society. So there, they work together and publish publications. So in those, you have that. When you go to that link, you have about 50 pages, 30 pages, manuscripts, sorry, the documents there. Those has how to treat community CAP, how to treat HAP, all those are there. After studying this lecture, go back and read once, okay? Let's look at it. Pneumonia, these are the basic things you learn from other lectures. You can read all those. Causes, okay. Bacteria causes about a lot of pneumonia, okay? Out of that, 65% is atypical and typical covering under community-associated pneumonia. So we are going to cover mainly bacterial pneumonia in this lecture. Okay, what do you have to, you learned everything, but this is a review part, okay? The first 2 slides maybe. Strep gram-positive bacteria is most common. Strep pneumoniae, most common cause of pneumonia. H. influenzae, CAP, underlying COPD cases, people mostly get this H. influenzae. But I remember this way, people when you go to, I live in New York City, so that's what I remember when I go out I don't drink, but when I go out with friends, I'll be the designated driver. They'll drink like a lot. So clubbing, whenever people say, I'll remember about alcohol. So keep in mind, Klebsiella has an relation with alcohol consumption. I'm sure you learned already in other lectures, but connected. So we need these for our lecture. That's why I'm specifying Klebsiella pneumonia. So connected with that, people can get it. Then atypical, there are 3 most commonly one. Mycoplasma, usually you will see that in younger than 40 years old. People who are like partying, crowd, people can get it. Chlamydophila. Then Legionella, I remember like legions, like a cruise, hotels, like a spas, air conditioning, all kind of things. Okay, just refer this and come back and do that. This is an abstract. Okay, Staph aureus, you can get pneumonia with the Staph aureus. Common one is MSSA, MSSA, methicillin sensitive Staph aureus. But MRSA will be also there in some patients. MRSA, we're going to cover that. Then viral and fungal are there. Okay, so you can read all those types. CAP. Okay. Acquired from community or hospital, staying less than 48 hours. Growing resistance is there now. Strep pneumonia is common. Atypical common one is Mycoplasma or Chlamydophila. These are the 3, that is strep pneumonia, and the rest of the 2 are the common community-associated pneumonia. HAP, after staying in hospital for 2 days, of course you learn all these in clinical also, but just to understand, nasty pathogens are there, a lot of virulent resistant, multi-drug resistant, beta-lactamase, you need to add, okay, beta-lactamase inhibitor you need to add because those pathogens can produce beta-lactamase. So these are the HAP might have MRSA, you need to cover MRSA, you need an antibiotic to treat MRSA, Pseudomonas, Klebsiella, Enterococcus, all those. Study at least 3 for today's lecture. We don't have time to discuss all those, okay? Ventilation-associated pneumonia, same thing. You have resistant pathogens, but they're greater than 48 to 72 hours, okay? Recommendation. Refer most recent American Thoracic Society recommendation. That's based on that. This lecture is based on that recommendation, okay? Most cases of pneumonia can be managed in outpatient setting. That means it's easy for you to just understand the mechanism of some of the pharmacokinetics of some of the drugs, and it will make sense why you treat that. MERS and Pseudomonas needs separate recommendations. Adult with a cap do not obtain sputum. That's this recommendation from this file. I looked at it. But empirically, you can do the therapy. That means you need to use your brain to connect, like wisdom, to use all those and connect and read the recommendation and stick with that. You can pretty much treat almost all the pneumonia with this if you can stick with that recommendation. If it is something really nasty pathogen or if this patient is really sick, that's the time you need like additional support. But otherwise, it's easy for you to treat. Let's look at it. Itroconsol, like I said, sometimes pneumonia caused by coccidium. These are fungal pneumonia, okay? Histoplasmosis, itroconsol is working well. Consider young patient is young or recommendation. In the recommendation, you will read all this. If the patient has comorbidity, are they 65-year-old, pregnant, all those things, right? Do they have recent antibiotic history? That means the chance of developing beta-lactamase and all the resistance chance is higher than CURB65. We will look at it, okay, what it is. Empirical antibiotic therapy is the cornerstone for treatment for pneumonia. Okay, now we are going to start. Focus now, okay? Evidence-based clinical recommendation indicated that macrolide, that is azithromycin, because I've seen that in many lectures, but do not trust that. Reason, it is not a monotherapy for any pneumonia according to recent recommendation. It is a poor choice for empirical monotherapy in most settings because resistance will be near or greater than 25%. I usually don't read through the lectures because while I'm reading it, these are important points. I don't know how else I can imprint on you, okay? That's why I'm reading with you. When you use macrolides for small okay, when do you use macrolide? Only when the patient is really, really healthy and very young and they can they are not in any risk, okay? For small subset of population, young, healthy, without any comorbidity, you can go for this. But that's not the first choice. CAP as outpatient, use macrolide. You can read that. Strep pneumonia, people use it, but this is resistant more than 25%. Look at the national averages, 25% resistant. Therefore, do not use macrolide azithromycin as a monotherapy to treat pneumonia because this is not working. It's increasing the resistance. A recommendation is in hospital setting, you can add with the ceftriaxone and azithromycin, or outpatient, you can add with other drugs. Okay, that is one of the important points. Then, okay, drugs for outpatient and hospital. How do you know? You learned that again in the other lecture, the physician's lecture. But for me to really start the pharmacology of all those drugs, you need to know the difference. If I'm telling that, how do you know outpatient or inpatient? There is a EC tip, CURB65 is the pneumonia severity score. If the patient has confusion, C. If the patient's blood has like too much uremia, U. Respiratory system, respiratory rate, is it high? R. B. Blood pressure, is it too low? B. Or the patient is 65-year or older. Does that make sense? Okay. If a score is below, okay, this is just the basic. To jump into pharmacology, I need to let you know the story. That's why. The details you learn it in future. But score below 2, if any of 2 is below, outpatient, you can trust that. What if it is 2? You get it? You can take decision. Look at the patient, how severe it is. If the patient is getting bad, like really sick, then you can hospitalize. Otherwise, you can give the medication and let them go. Or like for a couple of hours, you can give some drugs of trials or levofloxacin or something and let them go later with the other medication. We will discuss all those details. But low risk of mortality in this condition, that is the reason you can give us an outpatient. Does that make sense? That is an important point to understand. Then score above 3, that means you don't have to think anything, hospitalization for pneumonia, because it is high risk for mortality. That is a big point. Okay, let's start community-acquired pneumonia. Strategy, adult empiric treatment, it is outpatient. Beta-lactam is the primary drug to treat community-acquired pneumonia. There is no choice. There is a lot of choice in the list, but the primary one, recent recommendation, go with beta-lactam, it will work. You have choices like tetracycline. Monotherapy, you can trust this. Next point I am going to give you for indications of drugs. With comorbidities, if the patient is coming, but they are pretty healthy. Comorbidities, you may be asking, what is that, right? Okay, like a patient with asthma, COPD, like a renal or hepatic problem, uncontrolled diabetes, like maybe their spleen is splenectomy after that, a lot of complications. Does that make sense? So in that case, you can take this. Okay, so comorbidities, you cannot stick with amoxicillin, you need more. Or recent use of antibiotics, you can expect a lot of beta-lactamase activity. Therefore, you add amoxicillin clavulanate. Or you can stick with a monotherapy of respiratory fluoroquinolone. I'll tell you those details with another slide, but keep in mind to study from now, I know we already learned, but one more time, because this is respiratory section, and now is the time you're supposed to learn this drug very importantly. Like that's the reason. Levofloxacin is one of the respiratory fluoroquinolone. Never forget. There is one more called moxifloxacin. Levofloxacin is the best one. Okay, so we're going to go with that. We can do that. Or you have other choices. You can combine with one beta-lactam and doxycycline. Okay, still they are outpatient. This is the basic. Okay, look at it. So now what we are going to do is I'm going to go through each drug. Your role, this is the last time you're getting opportunity to review all those drugs. I will not do that again because I have a lot of other 20 more lectures. All those I will pick other drugs. Okay, this is the one last time. Of course, whatever slides I'm going to give the points that will be important for all your test and all. Okay, we will go from amoxicillin, then through this drug, then I'll introduce you another scenario. This is community-acquired pneumonia. You can send this patient home. Okay, let's look at it. We're going to use cell wall synthesis inhibitors first. Of course, when somebody asks you any of this drug, what is the mechanism of action? Go for cell wall synthesis inhibition. The second major group is glycopeptide vancomycin. That is also a cell wall synthesis inhibitor, but that is not a beta-lactam. Keep in mind, don't confuse. Okay, that's why I put it at the side. All the beta-lactams and glycopeptides can be, or it can kill bacteria directly. Why do you trust these drugs very well? Because these are bactericidal. That is a significant point to remember in pharmacology lectures. Then how do they work? They actually, why does it look like that? They're supposed to be, okay, it's missing. So there is, it's actually inhibiting penicillin binding protein. Beta-lactam, all the mechanisms, you can refer the previous lectures, but remember, how do they kill the bacteria? These drugs, penicillin, cephalosporin, carbapenems, and monobactam, all these are class. These classes of drugs can kill the bacteria by binding and blocking the beta-lactam ring. Therefore, they are called beta-lactams. Okay. First one, I'm going to give you 10 different patients in next 1 hour, okay? You have don't worry about the age but still to show you healthy. You have an adult healthy patient. There is no recent antibiotic history. Suspected strep pneumonia. You're going to give outpatient amoxicillin. This is based on the recent recommendation. So my role is to remind you all about amoxicillin. Recommendations, beta-lactams, or if there is any like allergy, or if the patient cannot tolerate, or if there is a history, you can go for doxycycline. Otherwise, first line is still amoxicillin. Children, first line is still amoxicillin. These are like direct sentences I took from that reference from CDC and all those links. Okay, amoxicillin, empiric treatment of CAP in adults and children, still first line and preferred agent. It is for outpatient, you can give it because you can trust that they can kill major pathogens for the community acquired pneumonia. Mechanism of action, I already mentioned, cell wall synthesis inhibitor, binds and blocks penicillin binding proteins. Rapidly absorbed, acid resistant, so that means if you have to give penicillin VK or some other drug, that is more acid liable, right? So this one is little more resistant. So there is no food interference. They can eat like 90% is bioavailable even if the patient mixes with the food. Higher sustained blood level, lower incidence of diarrhea, all this. Of course, I taught you in the first year, but you didn't need that time to treat a patient, so you didn't learn all those in detail, isn't it? So now I want you to remember all these points. What are the major adverse effects? I know you already know that even if I wake you up in the middle of the night, you need to say these drugs, isn't it? Like that's how I taught you before, right? So this is one last time. I will never do that again. Serious adverse effects of penicillins are or beta-lactam, IgE-mediated anaphylaxis. That will be very quick response. But if it is delayed, common adverse effects patients can get IgG-mediated rash. Amoxicillin has specific type of rash called maculopapular rash. Okay, I have a second patient. You have a second patient. This is also a healthy patient, suspected strep pneumonia, but the patient has a recent antibiotic history. No other problem to worry. The patient is pretty healthy, no other medication, no other illness. Since it is a recent antibiotic history, what is the first thing you will think about it? You are going to send the patient away because no risk of mortality or anything, right? You are adding clavulanate on that, amoxicillin clavulanate. Can you tell me what is the reason? What do you think recent antibiotic history? Beta-lactamase activity may be there. So you need to cover that also. When you give a patient a drug and send them home, what are you assuming? You are assuming that in the next 24, 48 hours the patient is cured. Cured means like all these bacteria most of the bacteria will be killed by these drugs and the patient will be getting better. That's what. So you need to use your brain. What do? You cannot give only amoxicillin. Okay, I need extra coverage. So you're going to go for amoxicillin clavulanate. Does that make sense? Okay, good. Indication you already learned. Now you need to learn the mechanism of action, all those details. So why do you add? How is it working? This is indication, empiric treatment of CAP, community associated pneumonia in adults with a recent history of antibiotic use. Okay? Or suspected beta-lactamase producing bacterial infection. So you should have a reason why you add. When amoxicillin is susceptible to beta-lactamase, if you are suspecting it is degrading, that means if amoxicillin will not be effective. That means you are going to add the clavulanase. It is an oral drug. Clavulanate pharmacokinetics similar to amoxicillin pharmacokinetics. That's why drug company added together and sending you. So you are going to just prescribe, they're going to get it together. Match with these two are matching. That's why this is the one, clavulanate is the one. Like for example, when I teach piperacillin, we talk about tazobactam. You don't combine tazobactam with amoxicillin, do you? No, because that doesn't match. The pharmacokinetics is matching with amoxicillin and clavulanate. Does that make sense? Those are the points you have to just get that basic. Okay. Same anaphylaxis and rash. Whatever you learn for amoxicillin, penicillin, those are shared with amoxicillin, clavulanate, etc. What is one extra thing you need to learn for amoxicillin, clavulanate when you prescribe to patient? Oh, normally all the antibiotics patients can get diarrhea, but these are community acquired, about 5 days short-term treatment, okay, if you are sending the patient home. But still, if you're really, really worried. So one of the points is clavulanate can increase the diarrhea. That means clavulanate is actually, when you add together, compared to amoxicillin alone, this can have more diarrhea. Just remember that, okay. Why add clavulanate? The main reason, you already know, still one more time, to inhibit bacterial enzyme beta-lactamase. Nobody else is going to tell you anymore. This is the last time you're going to listen about amoxicillin clavulanate. Does that make sense? Of course, I have to teach more in next classes, next 2 months, but I will not explain again. This is one last time, okay. Beta-lactamase inhibition, beta-lactam ring of clavulanate has no antibacterial activity. It cannot alone. If you give it alone, it's not going to kill. But bacteria will be there. Clavulanate is not going to kill bacteria, but this is a beta-lactamase enzyme. Enzyme is going to be chopped by clavulanate. Okay? You read everything. I think this is the one lecture. First 65 slides, I want you to read every line. Okay? Please do so. Why add clavulanate? We already discussed that. Okay. So you treat it. Can you treat 2 pneumonia patients? Can you treat a COVID-19 patient? Can you give an influenza flu drug? Okay, so we learned 4 things, right? Okay, very good. So we have a couple more patients. After this patient, I'm going to give you a break. Then after that, we'll start. Is that good? Okay, let's look at it. You have another healthy patient. You already know the patient has mycoplasma. Maybe the family member already got it or some other reason, like atypical pneumonia is mycoplasma. Right? If it is known, I told you earlier, azithromycin is not for a monotherapy if you are not there in your known mycoplasma. If it is known, you can go with azithromycin in very healthy patient without any comorbidities. Okay, and also if it is less than 25% resistance, that's another point. Otherwise, go with the doxycycline. So adding macrolide or doxycycline is recommended for non-mycoplasma. So let's look at azithromycin. It's a macrolide. Avoid if possible because it is increased resistance. You have to go back and refer that slide again. Atypical pneumonia, that's the coverage. This is extremely active against mycoplasma. How this drug work? Okay, we are going into second section. We are going from step by step, easy, getting harder and harder. But we already know cell wall synthesis inhibitors. Okay, we revised 2 drugs. Now we are going to protein synthesis inhibitor. Keep in mind, protein synthesis inhibitor, normally low doses are always bacteriostatic. Remember, if the patient is pretty sick, you can add because it can do only bacteriostatic level. Does that make sense? It will help why are you picking the healthy patients to give this drug? Reason, you are giving a bacteriostatic drug so that the patient's immune system can go and kill and remove all the bacteria from the body. Therefore, keep in mind the mechanism of action of this drug. Both doxycycline and azithromycin, protein synthesis inhibitor. How do you distinguish azithromycin and, okay, sorry, that is a wrong point. I'm sorry, I don't know how it came. I didn't proofread, I think. This is 50s, okay? What is the difference between, azithromycin and doxycycline. Azithromycin is a 50S ribosome inhibitor. Both are protein synthesis inhibitor. If somebody asks you, the other one is 30S ribosome. Okay. The next it's commonly called CPAC. It's a very long half-life. Once a day dosing is good. That's very good, right? Patient, you don't want to give a drug like a clindamycin or something for. Of course, it's not going to cover, but not a first line. Why we are not talking about clindamycin in this lecture? Because it is like a 3-4 time, like it's a very short half-life drug. But this one will cover, but longer half-life, persistent long after. You can read all those. Adverse effect is there. QT prolongation is reported. So azithromycin, study indication, mechanism of action, adverse effect. Okay, half-life that is related to pharmacokinetic. And okay, so take a break and come back after 10 minutes. Okay, we have about 10 more patients available. I'm going to pause. It's recording, right? Okay, hopefully. Okay. The next patient, you have a suspected atypical pneumonia, and you are assuming that is it's only suspecting, and you need double coverage. This is still CAP, outpatient. You can add, recommendation is beta-lactam you should give, but you can add doxycycline for atypical coverage. Okay, so we were discussing macrolide earlier. So in this patient, we're going to go for doxycycline. Let's look at what is doxycycline. This is an entirely different class. The previous drug was macrolide. Before that, we learned penicillins. Now we are learning tetracyclines, class tetracyclines. Indication, this has like a Clara, the stupid cat. That was your mnemonic I gave you last year. That's a long list of organisms you can treat up to the Lyme disease, right? So one of the diseases, pneumonia, you can treat with atypical. So this is indicated. Mechanism of action, protein synthesis inhibitor. This is targeting 30S ribosome. Pharmacokinetics, interaction with the milk and other calcium-containing drinks. There are 2 drugs. They can interact with the milk and calcium containing. If you give this drug, be a good physician, recommend them. What is the recommendation? Do not take the drug with the milk or anything. Absorption will be lower. Another important thing you need to advise, because if you forget everything, this is the one thing you need to remember. Tell them, do not expose to sunlight. What is the reason? Doxycycline will be absorbed into the body and the particles will be deposited in your skin. So your skin has keratinocytes. Keratinocytes, accumulation of doxycycline's halogenated compounds. When it exposed to UV light, is going to activate and become halogenated compound and give inflammation and itching complication. Phototoxicity is the major adverse effect I want you to remember. There are multiple. Please remember that one. Of course, some people get gastric discomfort, etc. There's another patient I have. But you understood, right? Do you want me to go through in detail of doxycycline? Because we already learned it last year. So refer that and just understand the basics. This is good for now. So start and revise everything. Then adult. Now we have hospitalized patient. Yeah, that means look at the curve 65 score. So if it is 2 and you are like confused or you are thinking like, okay, the patient has little, you are doubtful, so you can admit the into the hospital and not the ICU, okay? No. So levofloxacin. You can even give this as monotherapy. Very good drug. You must add respiratory, you cannot say must, but respiratory fluoroquinolone will work. Okay. So let's talk about fluoroquinolones now. Fluoroquinolones, what is it? Fluorine-containing drugs. That's the reason they got the name. I am not going to go through all this. What is the one thing to remember from this slide? I actually put it at the end, but now I bring it here to compare. Look at it. There are multiple drugs there, but big one is levofloxacin. What is the reason? Levofloxacin and moxifloxacin are the more recent, like a 3rd generation, 4th generation fluoroquinolones. Very well tolerated, more coverage. See that? Good gram-negative and positive coverage. And it can kill strep pneumonia. It can kill atypical bacteria. Pseudomonas coverage is there. Oh, that's good. And respiratory fluoroquinolone, that's why it's called. Then, other things. But here also you have coverage, but this has Pseudomonas. See that? Pseudomonas coverage for ciprofloxacin and levofloxacin, not moxifloxacin. Okay? So these are the points. Strep pneumonia covered better with the levofloxacin than the others. Now you know why we pick levofloxacin than other drugs. Always in pharmacology, that's what you need to compare with the other drugs and understand why you pick that. Okay? Let's look at it. So levofloxacin, it is respiratory, one of the respiratory fluoroquinolones, 3rd generation. Pneumonia is the indication. Increased coverage of it has gram-positive and atypical and gram-positive and gram-negative coverage and Pseudomonas coverage. I forgot to write it here. Not like a strong one. If a patient is hospitalized really sick, you can add this drug, but it's not that a primary monotherapy. Does that make sense? Keep in mind, but it has Pseudomonas coverage. Mechanism of action. This is an entirely different class. Earlier we learned penicillins, cell wall synthesis inhibition. Second class was macrolide, that was protein synthesis inhibition, 50S ribosome. And third class was tetracyclines, 30S ribosome inhibition. Fourth drug class is fluoroquinolone. Mechanism of action is entirely different. These are bactericidal antibiotics. Unlike macrolide and tetracyclines, these are bactericidal like penicillins. That's why very effective, and we are still stick with these drugs to treat pneumonia. Reason, keep in mind, bactericidal. How do they work? This is going to inhibit and break the DNA synthesis. Block the DNA synthesis. They break the DNA of the bacteria so that you can guarantee that you are going to kill the bacteria which cause pneumonia. Very good. Pharmacokinetics. What are the important things you need to learn from pharmacokinetics in detail for this drug? Because it is a most commonly used drug for pneumonia, and also it is pretty significant drug with a lot of coverage. So you need detailed study. Bioavailability is like I was talking about amoxicillin, clavulinate, all those, because these are bactericidal. Therefore, bioavailability is 95%. See, it's very good. Better pharmacokinetics, 1 pill a day, longer half-life. Therefore, and a renal elimination incompatible with as antacid. Okay, this is important reason. If you add sodium bicarbonate and all those, that can alter stomach pH, thus reduce absorption. Okay, here's the thing. You have to advise. For example, if you give doxycycline to the patient, you're going to advise saying, okay, make sure you don't expose to sunlight, because you tell the mechanism of action to the patient. Patient will be happy. Similarly, if you give levofloxacin, of course, this also has phototoxicity, but primary thing you should advise is do not take with antacids or milk or divalent cation. Reason, about 50% absorption reduction will be there. That means the patient will be still sick. Does that make sense? You cannot cure the patient because the drug is not going to absorb. Very important point. Reason, as for example, with the ciprofloxacin, about 50% reduction in absorption. That is not good. That means if a patient has pneumonia, it is a pretty serious matter to advise those patients about importance of antacids. But avoid antacids. Oral formulation will bind to cations. Read all those details. Okay. So do not administer concomitantly with the milk, calcium carbonate, etc. So remember, last year I already told you. You can go ahead and listen or read those also if you get time. Okay. I know you might not get, but just otherwise stick with this. They bind to these cations bind to the drug levofloxacin, thus prevent it from absorption. Hope you understood that What is the mechanism? That is why you should not mix with the milk or divalent cations or antacids. Fluoroquinolones with the Pseudomonas coverage. One more we have, that is levofloxacin. We already discussed. But keep in mind, the respiratory fluoroquinolones are levofloxacin and moxifloxacin. Okay. Adverse effects. They're not for children and pregnant nursing, contraindication, you already learned all those, but major adverse effect, there is tons, but at least remember one from each drug. Chondrotoxicity, that's tendinitis, that is a big one, okay? If it is high dose, long courses, it can get, okay? Next patient, you have a hospitalized care, pretty serious, empirical therapy, what do you do? That means like a hospitalization situation. I'm not talking about pretty serious condition, but you can add ceftriaxone. I have to teach you ceftriaxone, that's the reason we discussed this one. So ceftriaxone and, oh, what happened? What do you want? What do I have to do? I'm so sorry. No. Oh, it's okay. Okay, very good. Okay. So is it good? Okay, okay, thank you. Okay. So next patient, we have about 4 more patients, okay? We have to go faster because you have another lecture after this, okay? You have an adult hospitalization, you can treat with a ceftriaxone, okay? Like levofloxacin, this is a big drug for hospitalization. Levofloxacin is oral also. You can use oral pill and send the patient to home. Bactericidal, you used it. The next bactericidal drug, it is in the class cephalosporins. Remember, this is also a beta-lactam. It can guarantee that it can kill all the bacteria by targeting cell wall. Okay, so let's look at it. Ceftriaxone is the major drug. Of course, to cover, like, to get a broader spectrum, you can add azithromycin. Recommendation in hospital setting with other drugs. You can add ceftriaxone, fluoroquinolone, macrolide, doxycycline, anything you can come to second, but combined with the beta-lactam for double coverage. Beta-lactam, first one we discussed in the serious condition, the hospital situation is ceftriaxone. Okay, let's review our cephalosporins. I told you earlier, go refer in for the detail, but now for the pneumonia lectures, this is important. Listen, I may tell you, or in the hospital setting, you can use, instead of ceftriaxone, you can use cefuroxime, but don't worry about it. There are ceftaroline, we were discussing before, 5th generation cephalosporin with a MRSA coverage, but it is indicated, FDA indicated for methicillin-sensitive Staph aureus. It can also cover MRSA because it is expensive and rarely used drug. But what are you going to remember from this slide? These 3 drugs. You are not going to forget this one. Okay, let's do it. Generation 3, the previous slide we were discussing, the patient is in the hospital, you need some drug to cover the pathogens, you need a beta-lactam, you can give ceftriaxone. Where is that drug in the class, in the pharmacology? So it is a 3rd generation cephalosporin, ceftriaxone for hospital setting. Ceftazidime is a 3rd generation, another drug that has a Pseudomonas coverage. How I remember is dime for pseudo. Then cefapim, pime for pseudo, pp, pp. Okay, so cefapim is 4th generation cephalosporin. For this class, for pneumonia, basics, what you have to learn is, out of all these cephalosporin for hospital settings, 3 drugs to learn. Ceftriaxone for general coverage, first indication, hospital setting. If a patient is suspected Pseudomonas, I'm going to give you other drugs to study, but 2 drugs to learn, ceftazidime and cefapime, dime and pime. Okay, let's move on. Ceftriaxone, that's what. Still not. Okay, this drug does not have Pseudomonas coverage. That is an important point to distinguish. Keep in mind. Not this. If you mix all these cephalosporin, that is not having ceftriaxone, does not have Pseudomonas coverage. Okay. Indication, it is available IV and IM, commonly used IV, pneumonia at a hospital setting. With other drugs, you will treat this for pneumonia. Mechanism of action, this is a cell wall synthesis inhibitor like all the other penicillins, bind the penicillin binding protein and inhibit. Pharmacokinetics, half-life is about half-life, you don't have to memorize all those details, but remember, good option for renal impaired patients, metabolized by liver, excreted mainly through bile and feces. Still, there is no drug interaction, so it is good for renal impaired because it is completely metabolized by liver and feces. But there is one drug interaction I want you to learn. Here also there is a calcium story interaction. Remember, in previous section, I told you cation, divalent cation interaction, 2 classes of drug, 2 drugs, doxycycline and levofloxacin. Levofloxacin is the big drug for the pneumonia treatment. So about 50% reduction in the oral absorbent, therefore it is interacting with that. So if it is an outpatient, that is a different story. Here it is an inpatient, this is an IV drug, ceftriaxone. Here, you should never mix IV calcium with ceftriaxone. This drug can precipitate in patients' lungs and kidney, and they're going to lose lungs and kidney. We don't want to kill that patient by treating this drug. Does that make sense? Therefore, avoid, be careful, do not mix it. And if it is, especially this drug interaction is severe, if it is in neonates and elderly, okay? That is the drug interaction, okay? So that's all ceftriaxone. Now, if you want to study the adverse effect and the detailed adverse effect, I didn't bring it because it is just same like anaphylactic shock and what do you say, the minor adverse effect, but this is well-tolerated drug. Does that make sense? Even patients with a penicillin allergy, it's well-tolerated drug. You don't have to worry about with amoxicillin allergy or the ceftriaxone is commonly used in hospital setting. Okay, next section. A community acquired pneumonia normally will not be having resistant strains, but things changing nowadays, right? Everybody taking a lot of antibiotics, and if the pathogens are spreading around and they are mutating and a lot of resistance. Therefore, you can see often Pseudomonas or MRSA in community acquired pneumonia. But truly, when do you use Pseudomonas coverage and MRSA coverage? Both are in hospital setting. It may be for hospital acquired pneumonia or ventilator associated pneumonia. But still, that's what we are going to discuss those drugs, but I'm going to go in roughly what it is here because you may see for CAP also. But this slide, okay, all these slides are important. You don't want to delete anything, study everything, okay? So look at it. You need to use 2 drugs because it's kind of like you need to cover that, right? It's pretty serious. So need one of the anti-pseudomonal beta-lactam. Study now. You already learned 2 anti-pseudomonal beta-lactams. Can you pick 2 of them, whatever we learned earlier? Pime and dime. Did you see that? Where are they? First one, cefapime. That was a 4th generation cephalosporin, pime. Ceftazidime is the 3rd generation. So you have 2 drugs. Then you have a beta-lactam, piperacillin, tazobactam. Tazobactam is a beta-lactamase inhibitor, okay? So piperacillin is the drug. Next one, imipenem cilastatin. These are also, remember, we were talking about carbapenems. We will discuss that. Imipenem cilastatin also has, that is imipenem drug, that has also Pseudomonas coverage because they can kill Pseudomonas. Meropenem alternative. Reason, when do you use meropenem? If the patient gets seizure, because about 20 to like really high risk of seizure for imipenem in some patients, so therefore you should change to meropenem. So we will discuss all those details. Okay, you picked one beta-lactam for Pseudomonas coverage, study all the drugs name, then you need another drug. So you can trust levofloxacin. Tell me what are the three out of three fluoroquinolone, which are the drugs called respiratory fluoroquinolones? Moxifloxacin and levofloxacin, right? Okay. What are the two drugs with a Pseudomonas coverage? Not moxifloxacin, the Cipro, the previous one, not this respiratory, that was not respiratory fluoroquinolone, but the levo, respiratory fluoroquinolone. Does that make sense? So now we're going to stick with the levofloxacin. Are we good? Okay. You have choices, you can pick it, but study this way. You can combine a drug. When you read articles, you will see this combination, so you don't want to freak out. So the basic from this slide is you pick a beta-lactam and a pseudomonal fluoroquinolone. Now move on. What if a patient has suspected MRSA? Need one of the following. I already mentioned this. Vancomycin, IV only. Okay, do not even confuse. When do you use oral vancomycin? These are commonly like a simple basic science of the medicine. What is it? Yes, only when a patient has C. diff, diarrhea, Clostridium difficile, pseudomembranous colitis. That is the only time you use oral vancomycin. No other pathogens are treated with the systemic pathogens are treated with oral vancomycin. Please keep in mind, that's the basic. If you don't know that, people will laugh at you, okay? Please, those are very basic, because if you mess up, do not even think, just answer like that. Does that make sense? Those are the basic things, very good. Need one of the, I know you know all those, but still I'm just confirming that, okay? That means this should be IV to treat pneumonia, very good. Then linezolid, you have oral also available. That means if you have to send the patient home, you can still in the hospital setting, linezolid also for, okay, what is the benefit of linezolid? We will always go for vancomycin. But what if you have a vancomycin resistant strain? You can pick the linezolid, or even if you can alternate, sometimes people are more susceptible to Redman syndrome or previous history, although you can go for linezolid. Both are equally effective. This is just from their recommendation. I printed it out. You don't have to memorize the time or dosage or something. Okay, now, okay, we didn't learn that drug in detail, okay? These drugs, this means these two slides. These are the slides we are going to go in details in the next section, but under the heading hospital-acquired. Okay, hospital-acquired or ventilator-associated pneumonia. What are the major things I want you to study very seriously? Pseudomonas coverage, Klebsiella with the extended spectrum beta-lactamase coverage, and Staph aureus MSSA, you can cover with a lot of drug, but because even with ceftriaxone we already learned for hospital setting, levofloxacin, but MRSA, that is super important. Okay. Why is it very significant to treat with a multiple drug and a very seriously selective drug? Reason, hospital-acquired pneumonia acquired in the patient usually stay more than 48 hours after that, which you can learn all those. Patient is pretty sick enough to acquire this pathogen. Keep in mind, those are important points. So, hence, the condition will be more serious. They are more susceptible due to already weakened immune system. The patient is in the hospital for one of the reasons. Something went wrong, they are sick. So their immune system is weak. That's why they got this pathogen. That is the reason you are treating them aggressively with certain drugs. Often strep pneumonia, Pseudomonas aeruginosa is the major pathogen. Klebsiella pneumonia, Staphylococcus MRSA you should cover. Those are serious because they can make people die. That is the reason we are covering that. Ventilator-associated pneumonia, while the patient is using ventilator, you can read all those. Okay, next case. You have a suspected MRSA. Treat the patient, please. Ventilator-associated pneumonia. Hospital-associated, either way. Vancomycin IV. I don't have to discuss all those treated. On oral, we were discussing linezolid will be available. Strong recommendation, first line, vancomycin. That is a glycopeptide drug. Okay, vancomycin. What do you learn? I tried to put everything in one slide, but look at it. Indicated for pneumonia with a proven or suspected MRSA. Mechanism of action. This is still a cell wall synthesis inhibitor. Why we trust this medication? Because this is a bactericidal antibiotic. Keep in mind. It is IV you're supposed to use, not oral. Widely distributed it can distribute very well into the body. It can even penetrate cerebral spinal fluid. That's very good. Eliminate unchanged by the kidney and glomerular filtration. This is very significant because this is associated with the adverse effect, nephrotoxicity, because this drug is eliminated through the kidney. That means if you already have a patient with a serious illness, you can go for alternate medication, but should not combine with aminoglycosides, all those we learned earlier. But common adverse effect, I want you to learn 3 here. Usually I will teach you like 1, but Redman syndrome is the most common one. But it is like irreversible. When you stop this drug, it will be removed from the body. But it can prevent by adding antihistamines. If you give, patient don't get Redman syndrome. But irreversible adverse effects are nephrotoxicity and ototoxicity. There is another class of drug has same adverse effect, aminoglycoside. Therefore, contraindicated. Do not mix with that drugs. Okay, you already learned that. Then linezolid. This is a last resort drug. Why I just put last resort is easy to remember. So that is the mnemonic I remember. So it's actually that's right. You don't go for like a first line, and if a patient walking in with the community has a cap and a very healthy, it's not sickness, you don't give that. You cannot get it. Class, it is from a different class. It is not a cell wall synthesis inhibitor. This is actually a protein synthesis inhibitor, but it can kill MRSA and vancomycin resistant enterococcus, okay? And even all the vancomycin resistance can be covered with linezolid. This is a super drug, often reserved for multi-drug. Can you underline? I forgot to underline that. Multi-drug resistant infections. Very good drug, very effective. That's why you can trust this one. How this kill bacteria? By targeting. This has more bactericidal activity also. Generally, protein synthesis inhibitors only do static condition, but this is also have bactericidal activity. Protein synthesis about very good bioavailability. Oral drug is available, and adverse effect. Study 2 adverse effect: bone marrow suppression and serotonin. When you go to board exam, I want you to review this. Okay, both. If a patient already taken MAO inhibitor that morning, you should not give this linezolid because it will add up too much serotonin, life-threatening adverse effect with this antidepressant. So that is a drug interaction, and adverse effect is bone marrow suppression. Thrombocytopenia will be common for this drug. Okay. Okay. Next patient. You have a patient with a suspected MRSA, but Pseudomonas coverage you need it. you look at always curve 65, need a beta-lactam. Okay, I already told you, but we're going to revise this one more time. Pseudomonas, if you have to pick beta-lactam, we have more choices: imipenem, cilastatin, meropenem, all those. But we're going to pick from this: 4th generation cephalosporin, cefepime, 3rd generation cephalosporin, ceftaroline, and penicillin, piperacillin, tazobactam. So that means you can add add a beta-lactamase inhibitor with this. That's why tazobactam. Okay, let's look at this one by one. We didn't go through in detail. So the first drug for Pseudomonas coverage is cefepime. This is a 4th generation cephalosporin, so you know how it inhibits cell wall synthesis, same like penicillin. Broad spectrum. You cannot say broadest, but I have to correct that. Broad spectrum antibiotic. It's covered positive and negative. We learned that in the last year's lecture because it has a specific structural uniqueness of the structure can kill all this bacteria. Pneumonia with indicated for suspected Pseudomonas. Ventilator, especially patients with ventilator-associated pneumonia get Pseudomonas. The green color sputum, all those stories connect with that. And this drug can you look at it, have greater beta-lactamase resistance, excellent gram-negative coverage, including Pseudomonas. Immunocompromised patients, you can use this. Safe during pregnancy, very good. Can penetrate blood-brain barrier, very good. All these reasons, this is one of the drugs indicated for Pseudomonas coverage. You can read all those reasons. Okay, you can even use it for monotherapy. And adverse effect, neurotoxicity is reported. Ceftazidime, that is a 3rd generation cephalosporin, Pseudomonas coverage with any cell walls. Okay, so both this drug. Okay, forgot to mention. Cefepime also is a cell wall synthesis inhibitor, similar to other cephalosporin and beta-lactams. Penicillin binding protein binding. Ceftazidime, same thing. That's why cell wall, penicillin binding protein IV only. Possible cross reaction with the estrionum. That means you should not give estrionum with that is monobactam. Should not mix with the ceftazidime. That is the 3rd generation cephalosporin with Pseudomonas because it has drug interaction. Okay, we learned that in last year. Do not combine. Next one, penicillin, piperacillin, tazobactam, broad spectrum penicillin. Okay, beta-lactamase inhibitor. Tazobactam we will add. This has an adverse effect of thrombocytopenia. Next case, you have a patient with a Klebsiella pneumonia. The patient also has suspected extended spectrum beta-lactamase, so you need to add that specific drug. Okay, this is a direct indication. Like I said earlier, I don't usually teach like, okay, just memorize like that. All this content I put it in the slide, you can trust and study. Okay, please study. But I'm saying directly I can say that because it is indicated specifically for Klebsiella pneumonia, work really well. Imipenem, cilastatin. I want you to learn why do you add cilastatin and why do you go for meropenem or atropinum if imipenem works really well. Reason, imipenem has a major adverse effect. We're going to look at it. Imipenem works really, really well. But there is another one called atropinum. This one, usually you go for only early onset of, like if the patient has early symptoms, you're going to give that. But otherwise, stick with the meropenem or imipenem. But the first to go for drug is imipenem. Why do you add the statin, cilastatin? So class carbapenem. Okay, you have to learn that in detail. So extended spectrum beta-lactamase producing isolates are treated with the carbapenems, all those penem drugs, imipenem, meropenem, atropinum, all those. This can kill Klebsiella pneumonia. Klebsiella pneumonia has been frequently found to produce this bacteria, beta-lactamase. That is the reason we are picking that drug. Okay, infection caused by all the extended spectrum beta-lactamase. You can use it. Okay, currently you can read all those. Currently, imipenem or meropenem are the drug of choice for infections caused by extended spectrum beta-lactamase. This is not bold because if I am giving you the option, you have the first choice will be imipenem. Okay, study that way. I don't want you to overburden with the drugs, but at least study well whatever you are learning. Okay, first drug, imipenem. Why is it combined with cilastatin? We will learn. Carbapenem class. It is a beta-lactam, so it will block cell wall. Why do you trust this drug? Because it is a cell bactericidal antibiotic. It is also considered as a last resort class. Oh, it is not most, but it's a broad spectrum antibiotic. Oh, sorry. What did I do? 1 second. Okay. Delete. Okay. Okay. Broad spectrum activities there. Klebsiella pneumonia coverage, first line. It can cover all this, you can read all this. How this drug works? It inhibits the penicillin binding protein. Look at it. After entering, it is a gram-negative, like it can pass through the pores. Carbapenems can permanently acetylate penicillin binding protein. If a drug is permanently deactivating a protein in a bacteria, that is very good. It is covalently binding, very good. This is the reason. This is a very like a trustworthy drug. It can guarantee that it will kill those bacteria. Of course, there is resistance, but it is not that common. So efflux pump is there. You can read that. But adverse effect is mainly seizure is the adverse effect. Patients can get a lot of about 30% of patient reports 3 to 30%. But if to save the patient, we use this life-saving drug. But there is a risk. Therefore, if a patient already have a risk of seizure or have a history of seizure, you go for meropenem. Does that make sense? Okay. Look at that. Why adding cilastatin? Okay. Point. Imipenem, why do you switch imipenem to meropenem? That reason was because imipenem has a higher risk of seizure. But cilastatin, that why do you add with the imipenem? That is an entirely different reason. Please do not mix with that. I don't want you to worry about this one. This is also, to be smart, you need to understand this very well because these are very important aspects for your board exam and clinical practice. Cilastatin is a dihydropeptidase inhibitor. Study all those. Imipenem combined with cilastatin, a renal dihydropeptidase inhibitor, the cilastatin, which inhibit imipenem's metabolism into the nephrotoxic metabolite. If you give imipenem, this can excrete through the urine, it's well excreted out, but it formed the component as nephrotoxic to prevent. We already discussed in the last year, so you can revise those in the previous lecture. But decrease renal clearance of imipenem, because if the imipenem stay there and kill the renal tissue, patient will lose the kidney. To avoid that, you add cilastatin. Why? Decrease the renal clearance of, it inhibit the clearance. It will also eliminate faster. So combine with, I think I messed up something. Imipenem metabolite into nephrotoxic metabolite. That will prevent by. There are two mechanisms, but first mechanism is to prevent that nephrotoxic agent. Does that make sense? So it will be preventing the nephrotoxicity. That's the first point to remember. Okay, cilastatin can prevent nephrotoxicity. Also, this can prevent that nephrotoxicity and keep imipenem longer time. nephrotoxicity, reduction of nephrotoxicity is the big thing. Also, it will not eliminate faster. Two things for the cilastatin, imipenem, adverse effects, not to prevent the adverse effect of seizure, but to prevent nephrotoxicity. Does that make sense? I want you to study that in detail. Next drug is, next patient, we are almost done. You have a suspected pseudomonas with a patient with a beta-lactam allergy. I think we are almost done, but I want you to teach this drug also. If a patient has a, of course, people talk about penicillin allergy, beta-lactam allergy. When you go to clinic, you will realize in the real life, it's really, really less. Specifically certain, right? Amoxicillin or cephalexin, something like that. If you have amoxicillin allergy, you don't mix it with the first generation cephalosporin cephalexin, but you can trust with the third generation, fourth, fifth. Does that make sense? We learned all those in the first year. Similarly, but if you have a proven anaphylactic shock in a patient, beta-lactam allergy, that's proven. In that case, you have a drug which is well trusted, astrionum. So it is an aerobic, it can chop all the aerobic bacteria. So recommendations, add monobactam. So look at it, astrionum, only monobactam, restricted to treat. Remember I used to give you a picture, astrion oxygen, something like that, a picture I gave you last time for remembering the pneumonia. So this has pseudomonas coverage also, see? Beta-lactam is resistant drug, and this one restricted to infectious disease specialist. That's the reason I didn't teach you at first, because you cannot just give this drug like, oh, the patient has little bit penicillin allergy. No. You have to think about it, because this is like we don't want to make resistance. So these are the drugs, like last resort drugs. So that's why you need to get special permission to use these drugs, but still you have to study about them. And how they kill bacteria. These are, I think this is monobactam, I believe. Yes, that's right. It's a class of monobactam. These are also the beta-lactam antibiotic, but it will not have any cross-reactivity with its structure is very unique. That is the reason. Remember, do not have any cross-reactivity with any other beta-lactam. That is why it is a trustworthy drug to treat patients with beta-lactam allergy. Okay, and the rapid why it is specially reserved, and the infectious disease specialists have to approve for that reason. See, possible superinfection, because they can chop and kill all the bacteria in your body, so patients can get superinfection. We don't want that. No effect for gram-positive or anaerobes. It will not cover anaerobes. Okay. Aspiration pneumonia. I don't want you to memorize or anything, but just to understand, abnormal. You may learn in the other physician's lecture, but of course, study this for your board and clinical. But community, because you don't have time to study too much, right? At least if you can study up to this, we have a few more. We're not done, okay? So up to here, I think you treated about 10 patients, right? Okay, if I get time, at least we will revise in taking 2 minutes, okay, at the end. But let's look at it. Community-acquired aspiration pneumonia. You can use ampicillin sulbactam. I'm not going to teach the drug in detail, but this is an penicillin. Sulbactam is a beta-lactamase inhibitor. You already learned that in other lectures. Also, a combination of metronidazole, that is an entirely different drug. It is a DNA synthesis inhibitor. It can kill all the anaerobes, right? It's a prodrug, activated only in anaerobes. And amoxicillin you can add. Or in the hospital setting, you can give hospital-acquired aspiration pneumonia, vancomycin plus piperacillin and tazobactam. Nothing to memorize. Drugs to treat upper respiratory infection. We were starting. I put it at the end because I want to make sure I teach pneumonia really well without wasting any time. Okay, so this one, acute otitis, I already told you in the last year, so you already know that. Go to drugs still. First line is amoxicillin. You can trust that. Even very good for, because most of the patients will be children. Acute otitis media. So first line is amoxicillin. Why we include this in the respiratory symptoms? Because it's spread from respiratory system. That's why. If a patient has a recurrent acute otitis media, you can recommendation is you can go for clavulanate. Add clavulanate. You know the reason all those, amoxicillin clavulanate. Why do you use that? To cover the beta-lactamase, right? Inhibitor. Very good. Then or children, I told you before, this is a third generation cephalosporin. This has little broad spectrum. That's why I don't go for the first line. Okay. So cefdinir, that was like they have a liquid which is sweetened. Kids like to drink sweetened medication, right? That's why. That is the one syrup one available. It can be useful, and ceftriaxone in the hospital setting if it is serious. But otherwise, just study the first 3 drugs. Okay. But first drug is the primary one. Amoxicillin. The acute rhinosinusitis, amoxicillin is still the first line. But some physicians prescribe amoxicillin clavulanate. When you become physician, use your like a wisdom to treat that. But study all the basic pharmacology, then you can figure it out. Acute pharyngitis. What do you do? 80% time, acute pharyngitis will be viral. Only bacterial pharyngitis is most common in the United States. Strep throat, caused by strep pyogens, group S strep. So mainstay drug still uses penicillin VK. I don't want you to jump for too many other drugs. This is still very effective. This can kill those bacteria, so don't worry. It's the drug of choice. That's why I put it red. So this can kill that. No evidence that any other drug best than when you read the recommendation, and all those you will see all those sentences. So I put it there. Best than any other drugs are. No other drugs are like a super well coverage than penicillin VK. So you can trust penicillin VK. But if you need more recurrent infection, you can go for amoxicillin clavulanate. Or if a patient has penicillin allergy or beta-lactam allergy, you can go for doxycycline. Otherwise, stick with the penicillin VK. Are we good? Okay. And I think we are okay for the XR. Study up to here. Can you do that? Okay, let me take 1 minute to go through this slide. Can you do that? Okay, so you don't have to memorize anything. Ceftaroline, like I mentioned, just mersacarate. These are not the primary drug for the pneumonia, but why I add more pneumonia is if you like to read more, because Televans said this is a very good drug but expensive. But in future you may see this, okay? So that's why I included this. It will cover MRSA because it can also cover vancomycin resistant species. But we already have MRSA coverage, vancomycin and linezolid, right? So that's the reason this is not a first line, right? High rate of acute kidney injury is common. Aminoglycoside, not the first line like go-to drug, okay? That's why I didn't teach you earlier. Tobramycin, these are additional drug. Only if less toxicity, only if, when do you use? Only if no other less toxic antibiotics are effective. That time you can go for. Otherwise, do not even think about this one, because this will not mix with the vancomycin, because this has 2 adverse effects shared with the vancomycin, renal toxicity and water toxicity. So do not mix with. And fungal pneumonia, you have different types of fungal. Why I put it antifungal drugs. We already learned all those drugs: voriconazole, posaconazole, isavuconazole, and amphotericin B earlier. And sign and symptom, you can learn all those and see. You have links. You have pneumonia vaccine. This is not the pharmacology drug section, but still I put it there. You can learn that. Go to that website and read that. Patients can be treated with the vaccines. And HAP onset, how to recognize. Maybe the physician going to discuss all those details. HAP recommendation. Okay. When you go to this website, there will be like you can see that specific review article for recommendations like a fluoroquinolone. Why you use, why should not you use? You can see this explanations when you get time, or if you like to learn more, you can read it. This I just put it like I don't want you to study from this slide, but go back to any review, you can go ahead and look at it, but stick with the first 65 slides, okay? I prepared this slide at first, then I thought I can just leave it right here. And if you like to look at beta-lactamase producing bacteria and their enzyme, these are the enzyme, extended spectrum, this is super important for our, the Klebsiella pneumonia also, right? I was mentioning. And Pseudomonas coverage, you have all these drugs. This is directly from American Thoracic Society and Infectious Diseases recommendation from CDC. So that's the same thing I told you. No, you can trust, okay?